I'm Dr. Kendall Moore.
Hey, I'm Dr. Durrani, and welcome to Cuts and Consults. Today we have Melody Bishop on the show, who is a registered respiratory therapist, an EMS educator, a social media creator that puts out good educational RT and EMS related content, and a anesthesiologist assistant. Welcome to the show, Melody.
Well, thanks for having me. This is awesome.
Yeah, I think it's the best when that we kind of sent you a cold DM and we were like, hey, we love kind of the stuff you're putting on, and they talk about RTs on the show, but they don't really kind of go into depth. Would you be willing to come on? And you said yes. So thanks so much for agreeing to kind of come on through a cold DM.
Hey, you know what? I'm always willing to collaborate with other people that are in this sphere of putting out medical education. So again, thanks for I guess the cold DM. I appreciate it.
Yeah, absolutely. So I think obviously people who watch the show, they hear RT all the time, right? Like throughout even the first season, second season, they'll have, a respiratory case come in. They'll be like, call RT. And then I wish they would actually kind of go beyond that and show like in depth what an RT does, because we depend on y'all. So tell for those listening that maybe don't know what your role is, tell us what an RT does.
Well, I can give you the official term, or I can give you my romanticized version that I like to pretend that I am, and I think I'd like to go with that if you guys are okay with it. So
Yeah, works for us.
I like to think of RTs as like the hospital cowboy. We come in, we save the day, and then we ride off into the sunset, and most people don't even know that we were there. It's kind of like the hidden profession oftentimes in the hospital that people don't necessarily even remember when they're acutely ill that an RT was actively within their care, because most of the time the patients we're seeing are at their most critical, either those first few hours when they're coming into the emergency department and with respiratory distress, where we are actively, sometimes even before a physician has seen, working with extensive medical directives and initiating care in those first few moments. Or it's in the intensive care unit, where patients are often not necessarily conscious if they're sedated, or when they're intubated and on a ventilator. So again, most of the time, most people don't see an RT's full scope, and if people know about RTs, they mostly know it from either home care, CPAPs, things like that, home oxygen, or they know about it because their kid had asthma and they brought their kid into the hospital and they had someone come and teach them, how to use an air chamber and puffers. But it's kind of those critical moments where sometimes we don't necessarily have time to introduce ourselves fully, because there's so much of that, adrenaline going on in those crucial moments of either emergency or intensive care medicine. So in short, an RT is meant to treat patients that are in cardiorespiratory, acuity, but we also do extend into all aspects of respiratory care, even into chronic patients and home oxygen and trachs and all of those things. So we do encapsulate a lot, but mostly specific to the respiratory system. And we are the holder of many pieces of equipment that no one wants to learn. So we tend to have a lot of these secrets within our brain on how to pull out all of this magical equipment from the depths of the hospital in order to help these patients.
Yeah, that was a great explanation of what you guys do, man. You guys are very vital to what we do in the emergency department. Just speaking about the content you post, and I just want to know, at what point did you realize people needed this type of content that you started posting?
Yeah, I think mechanical ventilation, I've been practicing as an RT now almost 20 years from when I graduated, and it's something I hear constantly from nurses and different healthcare professions, that the vent scares them, or, oh, thank God you guys are here, because I'm lost when it comes to respiratory stuff. And I always would respond back, why? It's so easy, and I'm more than happy to teach you, because I truly do believe that the more we can learn about all of our own specialties and all of the things that we know individually, it makes us collectively better as a whole to work together as a team. So it's something that I've always tried to do, is expanding my knowledge and my role beyond just the RT sphere. And I like to pass my knowledge on to other people as well. And then specifically when I started to move into transport, I did that back in about 2017 is when I moved into transport. This is where I started working quite heavily with paramedics. And I feel such a special relationship with paramedicine in general. And I think RTs in general share a lot of similarities to that profession, that we're kind of on the outskirts of, we're not doctors, we're not nurses, but we do have such a vital role. And sometimes often forgotten in whether education or training or things like that, that I found specifically with paramedics that knowledge gap when it came to mechanical ventilation, even though it was starting to wander into their scope, was something that they didn't have great training on, or they didn't have exposure to great training. And that's kind of when I started getting really heavily into education. And then it's kind of exploded from there, with me really trying to just make it less scary for nurses, paramedics, and all of these other designations to kind of break down ventilation in a simple way so that they're not overwhelmed by it, because it doesn't have to be acronyms ad nauseum and calculations. You can really understand it from a lens of physiology.
Yeah, absolutely. And I was looking through content, and there's definitely things that I was like reminded on. And whenever you're going through like your ICU rotations in residency, you get really, really good at managing vents. And then when you go out into community, you have you guys, right, the RTs, and you guys are managing a bunch of it, so you're not thinking about it as in depth as you were when you were on that ICU rotation. And so I saw a lot of the stuff that you're posting. I'm like, oh yeah, I haven't thought about that in a while, but that's a good reminder. So definitely check her page out if you have any type of interaction with a vent, whether you're a nurse or a paramedic or a doc or a student. It can feel intimidating, but you lay it out very, very clearly and not as intimidating.
Thank you. That's very kind. That's honestly my goal. It really shouldn't be that scary. It's just, the chest goes up and down and the air goes in and out, and it really can be explained quite simply.
Yeah. So speaking of that, have you ever had anyone come up to you and say that like, the content that you post had a direct impact on their patient care that they were providing?
Yes, I have to say, like, I've now been in social media education specifically, heavily, mostly on Instagram for about a year and a half. So I'm actually still pretty new. And I have been very blessed to have a very supportive community, and people that seem to appreciate the education. And I would probably say daily I get DMs from people of like something that I posted, that they watched that video and then they saw it in real life and that they knew what to do. So it's definitely really rewarding to have those DMs, and it's also great to have those conversations and that relationship with people that like they know that if they reach out and send a DM or they have a screenshot of a waveform and they're like, what the heck is this? That I love taking the time to break it down and help them come to the realization of what they're looking at, and not necessarily just tell them the answer and kind of walk them through it. So I would say like almost daily, I get really great messages from people, which is just amazing.
Yeah, that really is. It's the thing I love about social media, one of the positives where you can reach people that you're not even seeing in front of you at the clinic or hospital and create a positive change and impact. So for those that may be listening that say, hey, I want to be an RT, what does the career path look like? Like what kind of schooling do you have to go through? How long does it take? Explain some of that to us.
Sure. So I will asterisk this with a disclaimer that I am Canadian. So my personal experience going into the RT program comes from the Canadian lens, which I know in the States it might be a little bit of a different story or a little bit different. But here in Canada, an RT license, essentially like you have to get it every single province, just like your states, but your schools are approved by a Canadian system, so it's kind of global across the country, so that schooling is the same, and I would hope it's the same in the US. So we are actually a non-degree program, so it's actually something that you do at a health school or a college, and it is a 3-year program here in Canada. Now, that being said, even though we are a non-degree program, in order to get into the program, it is quite competitive. So most RTs do have a degree when they are entering, or at least partial degrees. So it's 2 years of solid school and then a year of clinical, and then you write your board exams and you get your license for your province and then start working. And here in Canada, we only have one level of scope. If you graduate from as an RT, you are the same level of scope, and you can work in ICU or in the community. Like there's only one level, versus I know some provinces have like a multiple tiered system depending on how you score on your boards or things like that. So again, caveating this with the fact that I am in Canada, it is a 3-year program.
Yeah, very cool. What would you say is like one aspect of the job that maybe people don't realize, right? So you kind of alluded to like most people know them through like there maybe their family members in the ICU or in the ER. You all assist with a bunch of things, but what are some other things that maybe aren't apparent or clear or career paths that you could kind of go into if you are an RT?
That's a great question because I think I can go two different ways with that. So, number one thing about the job that I don't think is very apparent is how tech heavy it is and how much it is constantly evolving. Like the sheer amount of equipment that I learned even when I went in school and like what I was learning on versus what I am using on a daily basis in the hospital right now are night and day different. So it's a job that requires you to constantly evolve your practice as new technologies are coming out, and the expectation is that you are a master in this new equipment. So when it comes to advances within intensive care and within ventilation, like talking about esophageal balloons and talking about like EIT and some of these things, if you're at a hospital that becomes standard of care in the ICU, that might not have been something that you learned in school because it didn't exist when you went to school. But again, you have to evolve. For example, waveforms, I didn't learn in school. Now it is something that we use with every single patient on a ventilator and need to be a master in it. So this is a profession that is evolving at a rapid pace, not just with the studies that are coming out and staying on top of evidence-based medicine and evolutions within how to use a ventilator and how you're going to ventilate patients, but also with the equipment you're using. So it's extremely dynamic, I think, to an even higher level, because like even high flow, that didn't exist a couple years ago. Like all of these different things, it's so dynamic. And then for career paths for an RT, like I do have to say there is some opportunity to further your practice, but you tend to be, if you're an RT, other than going into education or management or sales, within kind of the same sphere. It doesn't necessarily have quite the broad ability to kind of diversify into different avenues as maybe nursing profession does, but that does not mean that you can't. And I think I am a great example of that, I started off as an RT and then I moved into anesthesia assistant, which in Canada, that's the equivalent of a CRNA type of role, which is kind of like an additional certification. You could also go to PA school if you wanted to afterwards. You can, and then again, as I mentioned, education or going into different avenues of RT, going into more home care or pulmonary functions or testing or things like that.
Very cool. Well, I'm the guy who's obsessed with tech and AI. Have you encountered any AI in the RT world? I'm sure there is, but have you encountered it personally?
Well, I think you could argue that some modes are starting to encroach on that idea. Currently, right now, I wouldn't say we have specific AI yet, but like come back to me in 5 years and I think my answer is going to be very different. And I love that you brought AI up because I have been dying to do a podcast dedicated on AI and RT because I think out of all professions, RT is a profession that if we're not careful, AI could potentially take a bite out of what we do. And like, I truly believe that like looking at the adaptive modes that already exist, once they actually get AI in, ventilation most likely in the next few years is going to be very heavily AI driven. And I don't think it's something to be scared of. I think it's just an opportunity for RTs to evolve again and become more. We are actually a young profession, and we have evolved from the 1970s of carrying oxygen tanks around to be where we are today. So why can't we pivot and become even more or more global or more diversified into different areas of critical care?
Yeah. Yeah, absolutely. It's well, like you and I work at like a freestanding ERs, right? And like the vents they have there are totally different than the vents they'll have at like the large hospitals. So I think like yes, AI will come to some point, is my opinion. But like, is every vent going to have those capabilities and whatnot? Probably not, right? Even today, if you go to like a rural hospital, the vents they have are like the ones from like the 90s or early 2000s, and they're not as nice as the ones you could have at like a large urban hospital. And so I think it's similar to kind of like we've talked about before, where you have to know the basics of it because you might have a cyber attack, or you may be working at a facility where they don't have the vent with the AI, and then what happens? So the fundamentals aren't going anywhere, and like you said, it just has to be looked at as an opportunity, but you still got to know your stuff.
And I think at the end of the day, there's always going to have oversight of said AI programs, right? So, but what definitely I think there is avenue for within respiratory would be changing ratios, right? So right now, most ICUs you're looking at one RT for 7 to 9 ventilators, sometimes more or less depending on the hospital you're in. But if you had AI driven, you could potentially have an RT remotely overseeing 30, 35 ventilators. It's definitely something that could happen. And with that, I think you could see a world that the number of RTs that are required in an ICU might decrease. And I think that's again the challenge that I like to put out to RTs of like, don't become replaceable, become better than a machine and become better than an algorithm, and don't think of your patient like a protocol, think of your patient globally and recognize when you have to step in, because someone can follow an algorithm, a computer can follow an algorithm, but to have the clinical acumen to be able to look in and be like, this isn't appropriate because of X, Y, or Z, that's the value of an RT and really where we would be able to shine.
Yeah, absolutely. So we've talked about a good amount about your career, and I feel like we could spend the rest of the hour talking about other aspects of, your job. And so my question is, does it frustrate you that on the Pitt, their extent of how much they talk about RTs is like grab the RT and then they don't go more into details? How is that for you?
I want to hear your opinions, actually, before I answer those questions. I feel like I've talked so much. Like, as physicians, do you like seeing other professions, or do you think that and like it's a TV show at the end of the day, right? It's Hollywood. It's never going to be accurate 100%. What are your thoughts?
I think they do a good job of trying to incorporate a lot of other specialties than most other TV shows. Again, it is a TV show. They stick to a lot of the dramas, medical field, and so they have brought in a lot of nurses, a lot of social workers, or things I think other shows don't bring in. They do mention RTs when they're trying to intubate someone, though, but I think they're doing a good job. They highlight some nurse practitioners, some nurses. They're doing best they can, but you got like 45 minutes or 50 minutes of show, so it's kind of hard to get everyone in there.
Yeah,
It's a lot of move parts in the show.
I feel like they're doing a good job, but they could do better, right? Like I think they did a great job of showing the social workers in season 1, and then they do a good job of showing them again in season 2, but like maybe cut down a little on the social worker because people now realize how important they are, and highlight another profession like RTs or like a bunch of other professions that exist in the hospital that I think also deserve a lot of attention and whatnot. And I think I'm biased, you're probably biased as well. Like we couldn't do our jobs without RTs. Like I think in the ER in particular, you guys are such a vital thing. Like that literally is what happens. A patient comes in respiratory distress, and the first thing you say is, "Did we call RT?" Or you get a phone call from EMS, and they're like, "Hey, we got a person coming in, CPR in progress," and you're like, "Are they intubated? No, they're not intubated. Is RT here?" And even if they are intubated, we still need RT. And so I think from my perspective, RTs are probably like near the top of like a vital team member when it comes to emergency medicine. And I feel like hopefully the next season they kind of delve deeper into the roles, responsibilities, and the vital component they provide to the care.
Yeah, it's not just intubations. Also, get that BiPAP ready sometimes too. It's like the BiPAP is always a big thing.
Yeah.
Yeah, I think you guys have hit it there 100%. Like I have to say overall, like I think they've done a great job. I really do. Like I'm not one to be like, wow, they didn't show this. Like at the end of the day, they went beyond what Grey's has done in 21 seasons, where you might hear an overhead page for an RT to go to a floor, or you might hear like, I think it's been like twice within the entire run of that show they've mentioned call the RT, and then they never show up. So I think it's pretty amazing that they've even tried. I had the exact same perspective of that. I was surprised that in an emergency department that the first secondary profession to be brought in wasn't the RT. But at the end of the day, like, I have no complaints, and I think that they've done such a great job, and I really, really appreciated social work. But I would like to see some PTOT. I know it's not as much in the emergency department as the ICU, but I think that's a profession that hasn't had any love that I would love to see, if there was a way to incorporate it. But again, I know with the emergency department versus ICU, it probably is a little bit more difficult. But yeah, I think it's great.
Yeah, I love that you brought up Grays. Like in Grays, the ER is still run by general surgery. That's like ERs from like the 1970s and 80s. Like emergency medicine isn't even a profession in that universe. So I think they have a ways to
Yeah.
go before getting to like all these other professions.
Yeah, I think like if I had a suggestion of what I'd like to see is just really showcasing maybe a difficult to ventilate patient where it is the RT saying to the doc like I'm working on this, and it's showing that like there is the profession there that is using that piece of equipment versus obviously it being the nurse in the background that's touching the vent or setting up the vent, which would again never happen. But I'd like to see anesthesia come in. Like they've done a really good job of bringing surgeons and different physicians in a pretty authentic role. But I'd love to see a difficult airway where they actually like call for anesthesia, because that's realistic for a lot of emergency departments, and that's something that I haven't seen that I think I'm even more surprised about. But what are your thoughts?
Yeah, no, I agree. Especially like all the episodes are blurring together now. We're officially covering 10. I'm not sure if you're fully caught up or not, but have you seen the episode where they do she does like the crazy crike or something, and then the general surgeon comes in and it's like, I'm going to clean up your mess and whatnot. Like I imagine they probably would have called anesthesia before they started doing all the crazy stuff in that situation.
Or season 1, they did a retrograde intubation. There was a couple things that like, I was just like, dude, they're in a hospital that's a teaching hospital. Like, that would be an automatic anesthesia overhead. And like, even if they don't arrive till after and they want the drama to be the emergency doc, just to see that they are calling for that profession to give them that, just bringing that profession in, I think that specialty in would be a really good thing because it is so realistic.
Yeah, absolutely. Are you all ready to start watching some clips?
Let's do it.
Walked out into traffic.
Reading Barnhill, wheezing, and not responding to albuterol. Colfax 87 is mother nailed.
Okay, trauma 2's open.
On our way. Mom, history of asthma?
His whole life. Never this bad.
Barely moving there.
Using all his accessory muscles.
Call RT. Continuous meds, 3 milligrams an hour.
Yeah, the whole nebulizer. I've been giving him albuterol every hour.
Ready? On my count. 1, 2, 3.
Does he take any other medications? Just the albuterol. He used to be on Montolopat and Semacort.
Why did you stop that?
Because he lost his Medicaid 2 months ago.
So tight. Now he's getting through. Now, EpiPen.
On it.
0.3 milligrams. That may open his lungs with the nibs.
All right, Grady, shot the thigh.
Awesome. So I think that's a perfect example of what actually happens, right? And you're going to call RT and hopefully they can kind of come in and rescue the day. I think you nailed it appropriately when you said you guys are like the Cowboys. And in that situation, you're like, oh, I want RT here. So hopefully they can, because usually what happens is here, EMS is giving the nebs and whatnot, and then that runs out. And then the nurses can't grab like the nebs in the hospital sometimes because RT has access to them, or RT has access to like, other medications or equipment that the nurses can't get. And you're like, okay, I need RT here right now so they can give me the tools and the best chance of, reversing what I'm seeing in front of me.
Yeah, I've worked at a couple different hospitals in my career, but the one that I've done the majority of my career in, it's more of a community, like it's still a larger community hospital, but we're normally patched from EMS when they're coming in. When they come in and say what they're bringing in, as soon as we hear asthma exacerbation, normally they're calling us down so that we are there before the patient rolls in the door. So instead of the multiple doctors receiving, it's actually an RT, and then this would be something that patient would be immediately on high flow and immediately probably already have the Aerogen that they call for later already in place and running before the physician even has gotten to the bedside, that is already waiting and ready to go. So it's, but I do love that they brought in that patient and showed that the RT would be automatically someone they would call for. And I appreciated that.
Yeah.
Yeah, it's ideal to have RT there before they get there, but sometimes with EMS, especially where we work at, they'll call and say we bring someone in, and they show up 10 seconds later, like they're already in the parking lot. But it is ideal to have RT there. BiPAP is needed, high flow is needed, have the nabs there, because at our hospital, our nurses don't give the albuterol breathing treatment. It is RT that gives those. I don't know if they have access to it or not, if they can give them, the nurses.
Yeah, I feel like they have access to it. Like, I think there's been like a time or two where like RT's like caught up with another sick patient, but like I think they just defer to RT because they know where it is, and you have to like mix a few things and whatnot, and they don't do it all the time, so they're not as quick at it.
Yeah, we normally do dual naps as well. I guess I got to mix the two together.
Yeah, yeah. What I'm curious, with you, have you ever had an RT intubate here in the States? Like, I know you've worked at other hospitals and whatnot. Have you ever had an RT intubate in front of you, like in the ER?
Not in Texas, in Indiana.
Yeah.
I did locums there. That hospital, it was their protocol to have RTs intubate.
Like just in the ER every time?
Yeah, it was in the ER.
Yeah, interesting. Yeah, I worked at a different hospital here a while back, and it's not like a protocol, but like there's an RT who loves to intubate, and he's always like, whenever anyone's on, he's like, is it okay if I intubate? And I love it because they intubate and put him on the vent, and I basically have to stand there and do nothing. So, what about? I know you work in the anesthesia field now, but before you did that, how common is it for an RT to intubate?
Very, very.
Very, okay.
Again, it depends on where you work. Teaching hospitals, sometimes it will be a lot less because there are so many residents and fellows and other doctors that are kind of there and readily available. But again, if you go out to community hospitals like my home hospital, all airways that are non-OR are pretty much default RT airways. And it was the running joke was that the doctor, if they hadn't done an intubation in a while, they would ask me permission, and I'd just laugh and be like, dude, it's your patient. Like, absolutely. So it's definitely, it depends on where you work, on what the normal protocol is. But yeah, here, like pretty much every art line and every intubation is default RT unless the physician wants to step in, or if it's perceived difficult, and then the RT hopefully checks their ego and says like, this probably should be physician or anesthesia.
Yeah, that's interesting. I don't know if I would want personally every airway for RT to do, because like you said, like you don't do them for like maybe like 6 months, and they're like, oh, can I intubate anymore or not? So you definitely don't want to get de-skilled, but it is nice to have them do it sometimes.
Yeah, I agree. I mean, I do enjoy doing them. I mean, so you want to get rusty at them. I'm getting to my career. I've done quite a few.
Yeah.
So you guys do art lines as well? So you do A lines for like blood pressure monitoring?
Yep.
Nice. I know you guys do art. They do ABGs at our hospital, but art lines for sure.
Yeah,
cool.
I don't think they've ever done art lines, or I don't think they're allowed, like, credentialed to do art lines.
I don't think we do art lines in our ER at all.
Yeah, I mean, I haven't done them either. But
Well, we don't.
Yeah.
Physicians don't do art lines either in our ER. We don't really get them upstairs. I guess they go upstairs quick enough to the ICU. I guess they don't need them in the ER.
One other question I had for you, since you're in Canada, one of the most common reasons we see asthma exacerbations, COPD exacerbations, all types of stuff come in is because people run out of their meds. Would you say that's common? And because they can't afford them is why they run out of their meds. Would you say, how common is that in Canada?
Very rarely, because we are universal healthcare up here. It would most likely, what we would potentially see is just like the patients that are reactive to weather or whatever. But when it comes to running out of meds, we don't have that experience. And I actually had that on my list of things to bring up for you guys to talk about, due to the clip having that in there, that they lost Medicaid, because that definitely is a different experience than we have here in Canada.
Yeah, and I personally am not sure, but I feel like a lot of these newer breathing treatments and steroids and whatnot are very expensive, and a lot of them are like only name brand. And so unlike, like, I'm sure albuterol is probably not that expensive, but a lot of these name brand things that are newer, and they're going to be a few $100s if you don't have insurance, which I feel is why a lot of patients can't afford them, unfortunately.
Run out of albuterol a lot. Yeah, you can actually buy nebulizer on Amazon now. I don't know. Before they need like a prescription to get it, but I've heard a few patients tell me they were able to purchase like a nebulizer on Amazon or even Facebook Marketplace, surprisingly.
Yeah. I'm not sure if I would buy it off Facebook Marketplace because that's been in someone else's home. You don't know what types of bacteria and stuff
But
has
if you
been
don't, if
around
you don't
it.
have one, you don't have one. Sometimes, you know.
Yeah. Yeah, I guess it's just like the device. So because we prescribe it from time to time,
Yeah.
but I guess without the medication, it's just a device. So someone's
Yeah.
still gonna need to prescribe you the medication. So
That's
that makes
true.
sense. Yeah.
Yeah, that's true. But I have a few patients tell me they bought some off Amazon because they couldn't get a prescription for it. So I didn't know that was a thing now.
Yeah. Do you personally have any idea how much they cost, a nebulizer?
No, I didn't look it up,
Yeah.
man. I'm it probably ranges from 100, 200. You can probably get some.
Yeah.
Facebook Marketplace might even be free.
Yeah. But pickup only.
Yeah.
That's the thing that I think people maybe don't realize is like a lot of times I'll have patients that I prescribe a medication or something. They're like, how much is it going to cost? And I have zero idea. And it's just because like A, it's not in our training, but B, like it literally may be like $10 at pharmacy A and they may go to pharmacy B and it may be like $80. Or sometimes it's really weird. I know this from like personal experience, like certain medications, it's just cheaper to pay cash pay versus like your insurance and doing the copay. That's sometimes more. And so it's such like a convoluted system that it's like impossible to know.
Yeah. The good thing about it, sometimes the pharmacy tech will let you know, like, hey, you probably paid out of pocket. It's going to be cheaper for you to do it
Yeah.
that way, which is crazy.
Yeah.
But there's a couple of websites you can go to and like kind of compare prices. I get people. We have those cards. We get people coupon cards sometimes to help out, but it's still kind of ridiculous, man. How much medication can cost and then variance between different like insurances, how much they cost, different pharmacies, how much they cost as well.
Yeah, absolutely. Anything else on this clip or anything else RT related in particular before we move on?
I was gonna comment on the epinephrine. Like, I was happy to see that they added epinephrine into that scene. But how did you guys feel about the dosing? Were you guys happy with 0.3, or like what's your protocol normally?
Was he a kid? I mean, 0.3 is kind of like a junior dose.
He's
So
a kid, yeah.
Maybe it was pediatric dose of 0.3, maybe. I think he was a kid, right?
Yeah. For an adult, you definitely give more. It kind of seems low, but he was a pediatric patient, so I don't know if that played a role. What it seems
Yeah,
like you, yeah.
But
I
it
know we
was
do
still
sub-Q. I
awesome
don't
to
really
see
stab
that
them.
they added the epi. I did find it interesting later on in the episode that they talked about Meg afterwards, but I don't remember them ever talking about steroids. And then again, kudos to the clip for later on talking about the Aerogen, but then again, the poor RT is relegated to be the one to run up the stairs and grab it from ICU, which I was like, oh, like, again, hopefully that an emerge department would have, or an ER department would have their own Aerogen, but hey, like, kudos to the RT for going to grab it.
Yeah. The other thing is like, obviously they have like an RT here. They have like a bunch of docs, nurses. And this is like a academic medical center. But like if you show up like in the same situation to like a community hospital at night at like 2 a.m. or maybe like a freestanding emergency department and whatnot, there is no RT there. There's like usually like one doc, a nurse, and, you know, maybe a tech. And those people are having to do everything. And like I said, there's no RT. They may not have Aerogen. They may not have a bunch of things. They'll have like the breathing treatment, steroids, epi, and all of that. But it is interesting, I think, because like people see this and then they expect that all hospitals are like this. But no, this is like a well-staffed, well-functioning hospital that they're showing here. And unfortunately, not every hospital is going to be able to give you that level of care. And that's just the reality. Awesome. Ready for the next clip?
Let's do it.
Brings you in today?
Friend made me come in. Name's Robbie. He said I should.
Ah, you're Duke. Donnie. Robbie's VIP is here.
Hi, I'm Donnie, nurse practitioner. Robbie's already put in orders for a numbing spray for your nostril.
Nostril, it's my throat. It's not my nose.
Okay, let's get you set up in the room.
Yeah, so a pretty short clip, but I did it because it talked about like VIP. So this is a friend of Robbie's who's like is a mechanic, someone he knows, has a good relationship with, seems right, and he has this person come in on a very hectic and busy day, and you see this patient come right in, and he's taken directly to the back and called like a VIP. So a VIP, like basically in a medical sense, not just like a celebrity or a famous person. A VIP can be like a hospital administrator. It could be another physician, like another person who works in the hospital, family, friends, a wealthy person with connections. So it's not just a famous person. So a VIP is kind of a broad term we use in the ER. And I wanted to point this clip out because a VIP is not just like, I think some people feel like if you're a VIP, you get better care. you're not getting better care. You're probably getting more care, and more care doesn't necessarily mean it's good. It's good for you. Sometimes it can lead to like a lot of unnecessary testing, imaging, and even procedures because you have this like fear of like not wanting to miss anything on this VIP. Also, taking care of VIPs can sometimes be very uncomfortable depending on the patients. Like I've experienced people that are great, like just normal patient interactions, but sometimes it can be uncomfortable. It can kind of lead you to do things you may be not comfortable with, some things you may not want to do. It can kind of put you in a position too, because like you have a VIP, and depending on who they are, you might not want to get a bad review from this person, you know. And again, you also, number one, you don't want to miss anything, you know, especially if someone famous hospital admin, you miss something, it seems pretty bad on you. You don't want to miss anything on any patient, though, at all. I'm going to say that, too, as well, though. But, you know, it can be pretty uncomfortable taking care of these people. And so you kind of go from, like, this practicing medicine to almost, like, managing someone's perception of how it should be. And, again, it's just, like, the way I look at VIPs is like I kind of try to treat them how I would treat any other patient because I've had experience before where I think I was a young guy. I was doing locum somewhere. He was a young guy. He's like a city councilman in the city. Guy's in his 20s and he had like, you know, a little bit of facial like numbness. It probably was Bell's palsy, but he was still moving his forehead, so they couldn't confirm. This guy went through like a litany of tests and he was in the ER all day. He was a really nice guy. He ordered the staff's food and everything, but had his own room and stuff like that. And it's kind of what, you know, being a VIP leads to those things. And again, I just want to iterate, like, being a VIP doesn't mean you get better care. You just get like you might get a room faster, might get more frequent checkups though. But you know you also may get more tests. But again, that's probably not going to always be the best thing for you. Like I don't know if you guys, you know, especially being RT, I'm pretty sure you probably had to deal with some VIPs as well. You, Durrani, I don't know how you guys feel about those.
I think similar to what you guys talk about, I think the only patients like that we deal with, like hospital administrators, all they get is like an asterisk on their account. There's like FYI, this is a manager or a CEO, family member or whatever. And we're just like, okay, but we're not going to do anything different. I think mostly it's coworkers. Like when a fellow nurse brings her kid in, and because they have group, and I'm responding, and inevitably, if it's a nurse's kid, they're gonna have the worst case ever that I've seen in months, and you're trying to like present that overall appearance of it's no big deal, like this is gonna be fine, but meanwhile you're like, oh my gosh, like of course this is happening, or like responding to a delivery for a fellow RT or the physician that you worked with, and now all of a sudden you are in the room when their infant is coming out. And I think those are the moments that I feel it more of, like just a little bit of that concern that this is one of our own kind of thing. I don't know. I didn't really. I understand for the public, they probably aren't familiar with that, but it's kind of one of the perks of working in healthcare to be able to maybe access a little bit of a quicker. We don't have many perks, but that's one of them, of being able to maybe get in and seen if you need to.
Yeah, even I mean, it's not as good as a perk as being like a flight attendant or a pilot and getting free flights. I mean, I think that's the ultimate perk. But yeah, I agree. Like, I think the only benefit it gives them is like you can not have to wait in the waiting room. You get in quicker. And I like to think that I don't want to miss anything on any of my patients. And so, like you said, with that, then you're like, oh, I can't miss anything. And so then I usually would say if I've had a VIP patient, I probably overorder, which is, once again, not good for them cost-wise, not good for the system. Maybe they're getting a scan. They don't need the extra radiation. But it's obviously done through shared decision-making. But like I feel like anytime you tell someone like, hey, we could either get this test or not, most people are going to be like, well, let's get it and see what happens kind of thing. And so everyone kind of sides toward that. The only time it kind of annoys me, like I'm like you kind of said, Melody, like I think it's like one of the perks of the job. That's fine. Yeah, you shouldn't have to wait 3 hours in the waiting room. I'm totally in agreement with that. The only time it annoys me is like I feel like a lot of the times I've taken care of those patients, everything's totally fine and it's normal. And that patient, if it was anyone else, I would discharge 99.9% of the time. And I tell them the same thing. I'm like, hey, we're going to discharge you, do this. And they're like, well, can I just stay, right? Can I stay at night and whatnot? And that it usually happens. And you're like, we're not going to do anything for you. And then you have to have the conversation with the admitting doctor and be kind of like, wink, wink, this person's a VIP. And that's why we're admitting them, because like there's usually not like a strong admissible diagnosis. And so I feel like a lot of times they end up taking up like an inpatient bed, which is, not good for the hospital.
Yeah. Yeah, for sure. Both of you, I agree with both of you guys. I said, especially Bellamy. Like because it's not that many perks. You have VIPs and everything, flight attendants, restaurants.
Yeah.
Durrani's a VIP on social media. He gets like free tickets to golf events and stuff like that all the time. So it's nice. You get medicine, you get some nice things.
Yeah. I mean, I took you to the golf tournament with me, so you got some of the VIP perks too. Awesome. Well, let's check out our last clip.
It's really hot in here. And you need to sit down. I'm good. I just need some air. Excuse me 1 second. Look out, Nick way. Get in. I'm okay. I'm okay. Get in the fucking chair. Excuse me. Coming through. Out of my way.
We're going to.
Okay, I'm okay.
You don't look okay.
You look like shit. I feel like shit.
What happened?
I don't know. I just got really hot and I started having trouble breathing.
We should set up some labs to be safe. Any chance you're pregnant?
Not sure I feel comfortable answering that. No.
She was tacky, but it's resolved now. Have you eaten anything?
Yeah?
You stayed hydrated?
100%. I'm doing everything right. It's everything around me that's all fucked up. It's just my mom moving and calling me over and over again, and now me scrambling to find a job next year. I had it all planned out, and now everything's just out the window.
Wait a minute. Is this a panic attack because of your mommy issues?
What? No.
Jesus. Do you need to go home? You should go home.
No, I'm fine.
I don't need the fucking liability. Go home. And the rest of you, last time I checked, the ED is a shit show, so let's all get back to work, huh?
Well, a lot happened in that clip. So I picked it for two main reasons. The first of all is I don't think people realize that we don't have like a backup call system in the emergency department. So I mean, some ERs might, but most ERs, like if you're working in the community, there's no backup person on call if you get sick. So if you get sick, you have to basically, in most kind of systems I've worked in, there's a group chat with all the docs on there. And you're basically like, hey, I'm feeling really, really bad and really sick. Can someone please pick up my shift? Now, people have their lives, right? They got their kids, they got trips planned. You're not just sitting at home waiting to, be like, oh, if you get sick, I'm going to be there kind of thing. Mm-hmm. And so it's very difficult to find coverage for when you're sick. And a lot of times what ends up happening is, like, best case, you at least go and start the shift and work a couple hours, and then maybe the director comes in once they can kind of get away from whatever they were doing, or maybe a colleague eventually kicks in. And so I don't think people realize that there's, like, no such thing as, like, sick days. Mm-hmm. The second part to that is emergency medicine, particularly in the United States, for most people is what we call 1099. So you're an independent contractor. So once again, there's no sick days. You don't go to work. You don't get paid. And it gets complicated, right? Like, say you break your foot and you have to be like bedbound or something, and you're missing like a bunch of work. You're not going to get paid for like half a month, whatever the case may be. So that's the second component to it. So I just thought it was important for people to realize that we have no backup call. You have to be really, really sick, like literally cannot get out of the bed, or you're going to get admitted yourself to like actually pull that card. And then the doozy on top of that is you're not going to get paid. So that was the first component of it. And then the second component of it was how Dr. Robbie was reacting to that whole situation. He I think in that scene perfectly shows how toxic he's become, how mentally kind of almost unstable he is. And I forget what the line is, like hurt people hurt people. Like, he's obviously hurt and he's taking that out on her. If she had a panic attack, there's a reason for that, right? She's under a lot of stress. Things are not right. You need to treat that with empathy, especially in a situation like this where you have other team members. Yeah, it's a busy day. There's a cyber attack. It's not ideal, but there's other team members that can kind of pitch in. And to treat her like that and say something like that out loud, like at this point of the season, like I'm like, he needs to be not on shift. He's going to hurt someone. He's going to make a bad decision. He's kind of reached way past that threshold, in my opinion. So a lot to kind of unpack in that clip.
Yeah, and one other, I love what you said there about his, like, the toxicity of his character. But one thing that I really wanted to bring up regarding that clip specifically is with the element of it being a woman on the table, having difficulty breathing and maybe some chest pain, and then jumping to anxiety so quickly, I was a little disappointed that there wasn't an opportunity for another doctor, because I think it fits the character of Robbie being in a little bit of a toxic state, and that he kind of was. I know other doctors stepped in and spoke to him later saying he wasn't good in that moment, but to maybe mention the narrative or the concern regarding often anxiety being, it should only be a diagnosis of exclusion, and specifically with women tending to have that, and not to get political or gender focused, but women tend to be labeled as emotional or anxious or all of these different things when they are potentially presenting with medical issues or problems, specifically MIs. I would have liked to see maybe a little bit of a spotlight put on that, because I think there could have been a really great moment of like, this is as an exclusion thing. So I don't know, just one little thought.
Yeah. No, I agree. Like you always have to rule out the medical emergency first. And obviously they're getting an EKG, he's talking about blood work, but like the minute she mentions her mom, he like becomes dismissive. He's like starts saying very toxic, nasty things. And like we see a ton of panic attacks and anxiety attacks that come to the ER. And what I usually say is like, hey, we're going to get a bunch of tests and we're going to make sure it's not a blood clot. We're going to make sure it's not your lungs or your heart. Would you be interested in like a medication that could help with your anxiety in case this is an anxiety attack? And so I laid out as a possibility, and I'm not like, you know, hey, it's this. And so I'm going to be dismissive of everything else that you're saying.
Yeah, man, a big part of that clip is like when the doctor gets sick, like what happens? Like you said, like you don't have any backup, that someone's there, someone's got to pick up the slack for you. And like you guys touched on for Robbie, like, the guy's really like burnt out. He needs to go on that sabbatical. I think. I hope he makes it. He gets it going, because I mean, you saw his character from the first season, how he was, and I don't think he reacted. And I also think some of what he went through with Langdon too as well. We talked about the liability, like the dude's just like on edge, and like that's still hanging over his head as well. He hasn't think he's resolved those things with how he handled the Langdon situation as well.
Yeah. It's honestly crazy. I'll be like on social media flipping through clips and whatnot, and I'll see like clips of him from like season 1. I'll be like, wow, that is not the same person. Like on season 1, he's like the person you want to look up to. And I'm like, oh, I want to be Dr. Robbie one day. And now I'm like, I don't want anything to do with him.
Yeah.
He needs a break. Give him a break. He'll come back recharge.
What have you have ever taken like an extended break from EM? Or like gone down on your shifts or anything like that?
I've been sick a few times, especially with here, and it's just like depending on the shift. This is like a midday shift, or you can find coverage. If it's like a weekend, like overnight, you're gonna have a hard time finding coverage. Yeah. So I've had to push through a few times with some fevers and things like that. I mean, especially having kids, they get sick of daycare every week, and I get sick maybe every 2 or 3 months. So I go through it. But like I said, it's just rough that we don't have a system. So yeah, if you have a weekend shift overnight, you're probably not gonna find coverage. If it's like a weekday, you probably be lucky at getting out of your shift though. But I've taken about a month or two off at one point, just for vacation wise. Nothing like unplanned.
Nothing like Dr. Robbie level. What? Yeah. I mean, honestly, there's been times where I felt sicker than like the patients I've been taking care for. I'm like, man, you're here, but I feel like I'm like way sicker than you are, and you can like barely talk, and it's you feel not so great.
Yeah, my knee at one time, I hurt my knee for like a month, and I was on a cane.
Yeah.
Yeah.
Was that recently?
We were working together. I don't know if you remember. I hurt my knee doing some stuff. So I was on cane and the crutches for about a month, walking around.
Oh wow!
Taking care of people.
Yeah, it's not fun. Well, Melody, where can people find you? Where can they follow you? Any parting words of wisdom?
Yeah, if people are interested in some mechanical ventilation free education and just overall like respiratory topics, I'm mostly on Instagram. I do have a TikTok and a Facebook, but my Instagram handle is at melodybishop_RT. I do have a free book that is accessible online. That the link is in my profile, that overviews the very basics of mechanical ventilation for just people that want to start from scratch and get a fundamental understanding of how not to hurt someone with a machine. It's, again, the link is on my page. And I'm just always willing to help people out with different topics if they ever have DMs.
Perfect. Thanks a lot. I'm going to check that book out for sure.
Yeah, thanks so much for sharing that and joining us. And hopefully the folks that work on the show listen to this and they can consult you to have an RT character that's more in depth for next season. But thanks so much for joining us.
Thanks, Melody.
Thanks so much for the invitation, guys.
Awesome. Thanks for joining us for another episode of Cuts and Consults. It really helps us if you like and share this episode or any other episode with your friends.
And if you'd like to be a guest on our show or if you have any feedback, please hit us up. Again, I'm Dr. Moore, and
I'm Dr. Durrani, signing off.